I'm Laura Timmis, and I'm presenting on a Northwest Cancer Research Impact Grant that measured the impact of frailty and geographic location on cancer treatment decision making, which was a novel approach to benefit risk assessment in North Wales. The research was carried out at the Centre for Health Economics and Medicine's evaluation at Bangor University in conjunction with Liverpool Hepatology Centre and Betsy Cadwallader University Health Board. So, over 250,000 people in the UK are living with colorectal cancer, and over 50% of these patients will develop liver metastases at some point in their lifetime. An increasing proportion of patients will be suitable for surgical resection, which offers significantly higher 5-year survival than chemotherapy and local ablative techniques such as radiotherapy and microwave ablation. However, all options have associated risks of harm, for example, adverse events and toxicity that impact on patients' quality of life. It is known that frail patients have an increased risk of mortality from colorectal cancer, and patients in North Wales who might be suitable for surgical resection are referred to a supraregional hepatology centre that for some patients in North Wales might be over 100 miles from their home address, whereas systemic anti-cancer therapy can be delivered locally. The aim of this study was to elicit patients' preferences and healthcare professionals' preferences for the benefits and risks of treatments for colorectal liver metastases in North West England and North Wales. So we wanted to identify whether the acceptable trade-offs between the risks and benefits of treatment differ between different subgroups. For example, for patients, the age and frailty and geographic location, and to healthcare professionals, for example, surgeon, clinician, and clinical nurse specialists. We wanted to demonstrate the impact of incorporating patients' benefit risk preferences into clinical evidence and practice with an aim to improve patient care. So the 4-stage method. Stage 1 was a literature review of treatment options and outcomes. Stage 2, a mixed method ranking exercise with patients to explore the relevance and interpretation of the identified treatment outcomes. Stage 3, an online survey which included a statement preference discrete choice experiment where respondents were asked to choose between hypothetical alternatives described by the attributes, for example, survival and adverse event risk, each with varying levels, for example, 1 in 1,000 or 1 in 100. In stage 4, modelling modality ranked by population, for example, patient or healthcare professional, and for frailty and location subgroups. So the literature review of treatment options and outcomes. We reviewed the latest NICE guidance and the evidence used to inform them. There are 18 guidelines and 54 empirical papers used to inform these, and so a total of 72 records which were screened and assessed for eligibility. So 38 of these were excluded, and relating to the guidance, 3 of these were not relevant specifically to the research question. One of these guidance was not specific to the UK. That's the ESMO guidance, which we originally decided to look at and then subsequently excluded. And then 2 of these guidance were updated throughout the course of the literature review. Regarding empirical papers, 22 of these were published before 2010. It's important to keep to this time frame due to the advancements of treatment and the effect this had on respective outcomes. And 4 of these, the population was not limited to colorectal liver metastases, and they did not analyse results by the disease type. So therefore, 34 papers were included, 12 of these were guidelines, and 22 empirical papers. The literature review identified heterogeneous outcomes, including survival, both overall survival and then 1 to 5 year survival, progression-free survival, again overall and 1 to 5 year, and then operative outcomes, for example, blood loss and length of post-operative stay, as well as adverse events. These were listed as well as by grade and listed by grade. The mixed method ranking exercises with patients to explore the relevance and interpretation of the identified treatment outcomes. It was originally proposed that we would conduct iterative face-to-face interviews comprised of ranking tasks and brief qualitative questions to explore the relevance, saliency and interpretation of treatment outcomes identified from the literature review, and to identify how different subgroups of patients prioritise these outcomes to ensure the understanding and comprehension of the DC task that we used in stage 3. However, due to COVID, this proposed a bit of a barrier to recruitment to this study. So it is proposed it will either conduct brief ranking exercises using Bristol online surveys, recruiting participants from local hospitals, or piloting the survey using the first approximately 10 participants. And the option shows will be dependent on resource availability. The online survey, including the discrete choice experiment, over 94 patients and at least 47 healthcare professionals will be recruited. The measures of frailty and geographic location in the patient population will be the Tilburg Frailty Index, which was chosen as it is to be able to be completed online and without the support of a healthcare professional, and its validity and reliability. And the geographic locations questions were: what is the first part of your postcode, and approximately how long does it take you or would it take you to travel to an appointment with a surgeon or receive surgery if they are eligible, and if they're happy to travel that distance. Patients and healthcare professionals will be recruited via personalised invitation, advertisements in clinics, and at relevant conference and study days for healthcare professionals. So patients and healthcare professionals will be presented with an introductory animation to explain the risks and benefits described in the DCE choices. For example, 5-year survival, risk of toxicity, and risk of complication. And you can see how, using the illustration, how the actual attribute levels may vary. For example, 5 in 10 people will be alive versus 1 in 10 people will be alive. For 5-year survival, risk of toxicity, 2 in 10 people would experience treatment-related toxicity versus 4 in 10 people, and then 10 in 100 would experience complications versus 2 in 100 would experience complications, and then participants will be required to put a tick in the appropriate box for which treatment they prefer. So as you can see, the DCE, whilst presented, in some ways it's quite complex, it's quite simple for patients and healthcare professionals to understand and make a treatment decision. So stage 4, developing a preference-weighted utility model. So we will model the impact of patients' preferences on the existing evidence using the preference weights listed from the DCE, using to weight the evidence identified in the literature review. So we will estimate the total utility of each treatment modality identified in stage 1, for example, surgery and radiotherapy. And the options will be ranked in order of probability by uptake and by subgroup based on frailty and geographic location. So in conclusion, comparing the preferences of different stakeholders, so patients and healthcare professionals, and by subgroup, for example, frailty and geographic location, will provide information on how these acceptable trade-offs differ and help to increase awareness of patients' preferences. This will add to the literature on the impact of frailty and geographic location in colorectal cancer and patients' treatment decision making. DCEs are a well-established, valid and reliable method for understanding the acceptable trade-offs between the benefits and harms of treatment. Exploring what people living with cancer consider important is crucial to ensuring that clinical services are focused on patient-defined needs and that future research is designed to assess appropriate patient-defined outcomes. The formative work of the literature review and ranking piloting will help to ensure that the attributes in the discrete choice experiment are valid and meet the requirements of attribute generation. And this study will provide an exemplar that can be used in the evaluation of other cancers or surgeries to improve, with an aim to improve patient care. Thank you for listening. If you have any questions, please email the Principal Investigator, Dr. Emily Holmes. Her email address is on the front slide. Thank you very much.